Welcome to the Smooth Brain Society podcast. Have you ever come across something and thought, I'm not smart enough for this? We think the fault lies with those who present information in ways which are hard to understand. In an attempt to change this, we'll be speaking to researchers, experts, and all-round wrinkly-brained individuals, improving our understanding of a broad range of topics which are rooted in psychology. Join us as we try to develop ourselves one brain fold at a time.
Please note that the Smooth Brain Society podcast is distinct from the Herenga Waka, Victoria University of Wellington. The views expressed on this show are those of our guests, presenters, and affiliates alone, and we assume no liability for the application of the information discussed. We also take no responsibility for any change in brain folds on part of the audience. Viewer discretion is advised. Now on to the podcast. Welcome back to the Smooth Brain Society. I am Sahid, and Olivia is not with me today. Today, instead, we have Royden Goldsax.
G'day.
So, just for the audience, could you tell us a little bit about yourself, Royden? Yeah.
So I am in my fifth year studying my master's in psychology. Just completed my honours in statistics last year. I am Wellington, New Zealand, born and raised. And my kind of area of study is in kind of emotion or empathy, kind of very broadly.
Well, and sorry, one more thing is you were part of the original demo Smooth Brain podcast, which we did. Isn't that right?
It is. Long may that stay in the archive.
Yep. Let's hope that never sees the light of day. All right. And our topic today is brain injury and, TBI, which is traumatic brain injury. And as I've done for all the episodes so far, I've found a quote in a different language just to kind of capture the theme. And I've gone and found one in Latvian this week that goes, Viena secunde lai savainotu smagenes meneshi ungadi lai atkutos, which translates to 1 second to injure the brain, but it takes months and years to recover. And I think that fits perfectly. Our guest is Josh Faulkner, Dr. Josh Faulkner. He completed his PhD in neuropsychology and clinical psychology training at Victoria University of Wellington. Since then, he has worked as a clinical psychologist and neuropsychologist in a range of clinical settings, including adult and child mental health, TBI rehab, pediatric and adult physical rehab services as well. He completed a postdoctoral research fellowship in the TBI network at Auckland University of Technology and currently co-leads the neuropsychology lab at Victoria University of Wellington. So welcome, Josh.
Thank you. It's great to be here.
We'll start off how we generally do. Could you take us on a journey a little bit of how you got interested in this field? And
Yeah, sure. Great place to start. So for me, I've always had a long-standing fascination in the brain and how the brain functions and also what happens when there is dysfunction, illness, or injury to the brain. And that particularly got sparked, as many of you would be familiar with the work of Oliver Sacks. And I vividly remember reading with awe his book, The Man Who Mistook His Wife for a Hat, and just being absolutely captivated by the brain, the mysteries of the brain, and all of the things that occur when there is dysfunction and illness. So that really triggered me into a pathway of knowing quite early on in my studies that clinical neuropsychology was the pathway I wanted to go on. So I did a undergraduate degree at University of Otago in neuroscience, which was sort of really the biological, the physiological, the anatomical basis of the brain, which was incredibly fascinating. But I've also always wanted to work with people and to work in clinical settings. And very early on in the undergraduate degree, I was exposed to clinical neuropsychology, which was really the ability to learn about the brain, to understand all of its mysteries, and also then to work with people and to help people. So then I did a double in psychology and then applied to become a clinical psychologist through the clinical psychology program at Victoria University. And yeah, as I mentioned earlier, just knowing that I was sort of always wanting to be a neuropsychologist didn't really waver. I was incredibly fortunate to develop a really great relationship with my supervisor and now my mentor, Dr. Carolyn Wilshire, who exposed me to working with neurological conditions, and I got the opportunity to work at Wellington Hospital. And so my focus of my PhD was working with people who have a brain tumour and trying to understand the impacts of a brain tumour on an aspect of cognition. And what I mean by cognition is just our basic thinking skills, our ability to communicate, our ability to remember things, our ability to think, really. And part of neuropsychology and clinical neuropsychology is understanding how a person's thinking skills have been impacted by some form of neurological disease or illness or injury. And so for the focus of my research, we wanted to look at how a brain tumour might impact a very specific aspect of cognition or thinking, which is one's language skills. And this research really got triggered because people who have a brain tumour may undergo what's called an awake craniotomy. And an awake craniotomy is, again, highlighting just how incredibly fascinating the brain is that the brain doesn't have pain receptors. So what a surgeon can do is that they can put somebody under a local anaesthetic and can do what's called a craniotomy and go into the brain and have the person awake when the surgery is happening. And surgeons do this so that they can monitor cognition or thinking skills or language whilst they are removing the tumour. So it's this brilliant way of being able to monitor in real time the impact that surgery is having on the amount of tissue that's being removed. So the surgeon would be able to know, they sort of stimulate around the tumour boundaries and are able to determine that if stimulation causes an impact on a language skill or an aspect of thinking, then that part of the brain is really important for that aspect of cognition, and then they won't resect or go into that bit of brain tissue. And so the neurosurgeons are really monitoring language in particular in real time during these surgeries, and how they do that is that they work with either a neuropsychologist or a speech language therapist, and they give them tasks to complete when the surgery is happening. It's kind of a sensitive way of being able to isolate a specific part of one's language skills. And although this is a really great technique, one of the challenges that has arisen is that a lot of the tasks that are often used intraoperatively aren't that sensitive at picking up very subtle differences in people's language skills. So often they do an object naming task, so see a picture, and they will say that's a cup, for example. But we know that there's far more other aspects of language. So with Carolyn's expertise in cognitive neuropsychology, we developed a test battery where we could hone in on different aspects of language. So being able to repeat words, being able to understand words, a more comprehension component, or being able to break down some of the other aspects of speech production, we could look more specifically at how the tumour might be impacting these aspects of language. So we would administer this battery before, sometimes during and after their surgery, to be able to get a bit more of a detailed, more sensitive understanding of how the tumour might be impacting their language skills. So that was really the basis of my PhD, and it just highlighted the love that I have for the human brain, the love I have for working with people and being able to understand all the intricacies that arise when there is some type of dysfunction to the brain. But in New Zealand, one first has to train as a clinical psychologist before they become a neuropsychologist. So as part of my training, we get a foundational grounding in mental health, clinical psychology skills, and hence working in mental health settings. And then following the completion of my clinical training and my PhD, I then specialised post-qualification into neuropsychology. And in order to do that here in New Zealand and in other places around the sea, overseas, you work in a specialist field where you have to practice clinical neuropsychology skills under close supervision, where you expose yourself and you train further in this more specialized field within clinical psychology. And so I then worked in a brain injury rehabilitation service, and a brain injury rehabilitation service is focused specifically on helping and supporting individuals who've experienced a traumatic brain injury to rehabilitate or to recover from their injury. And in New Zealand and in a lot of services, these rehabilitation services are split into an inpatient service. So these are for individuals who've experienced a severe traumatic brain injury and are needing intensive interdisciplinary input. And they have an outpatient service. And these are for people who've had either a mild injury or that they're supporting individuals who've had a more severe injury but are developing a degree of independence to help support that independence away from a more hospital-based inpatient setting. And then I worked in traumatic brain injury services for a couple of years, and that sort of sparked an ongoing interest into researching and understanding traumatic brain injury, which has now sort of become the focal point of my research and the work that I'm doing.
So in your current research then, are there any specific things which you look at in terms of brain injury?
Yeah, I focus more specifically on the mild injuries. So we know that there is a spectrum of traumatic brain injury which reflects how severe the injury has been to the brain. And when I mentioned earlier the different rehabilitation services that occur for people who've experienced a TBI, that reflects the severity. So we can have a severe traumatic brain injury which is associated with quite a sustained period of loss of consciousness, notable damage to the brain, and then those individuals are likely to experience quite significant difficulties as a result of that injury. And so there's the severe injury, but then all the way through the spectrum we have the more mild TBI, or those that have a concussion. They are the same thing. And my research focuses more on the mild spectrum. And I got really interested in this area because when I was working in the two services, I was working with individuals with a severe TBI, really significant injury, and a lot of these individuals would make quite significant improvements in their recovery in that really early stage. And that was reflective, I guess, of the intensity of the input, the rehabilitation that they were having. But it just fascinated me that these individuals who'd had such significant injuries were able to recover and make such gains in their ability to manage the symptoms or the challenges that they're experiencing. Not always the case. We know that some have more permanent difficulties, but there was this real notable difference in my outpatient and inpatient work where I was seeing these big gains. And then when I'd go and work in the community and working with individuals with more mild injury, I was often seeing that a lot of these individuals were having quite significant long-term difficulties, even though their injury was on the more mild end. So sometimes these individuals would be a year, 2 years, 3 years post their injury, and were still not able to return back to work, were still having real issues going out and just living their life that they used to live before their injury. So that really triggered my fascination in terms of, what's going on with these individuals. They've had a more mild injury, but yet why are some of them suffering so much? And what's going on when it comes to trying to understand the recovery and supporting people who've had a mild traumatic brain injury? And so as a psychologist or as a neuropsychologist working with people with concussion, we often focus not only on the cognitive implications or the effects of the injury on their thinking skills, but also what is the emotional toll of the injury. And understandably, the emotional toll can be really, really significant for a lot of people who've experienced a concussion. If you think of the young sportsman who is trained in his life, is totally devoted to being the best athlete that he can possibly be. He's about to enter the finals. He experiences a concussion and then is not going to be able to play, is still having headaches, can't train, can't do all those things that he loves. Then understandably that's going to trigger feelings of anxiety, depression, low mood, stress. And when I was working with these people, I began to see how much that emotional toll was having on their recovery and how much it was impacting their symptoms and their ability to recover from their injury. And that's really well supported in the literature. So we know that individuals who've had a mild TBI will experience what's called post-concussion symptoms. So these are all the symptoms that you would experience after you've had a concussion. They're physical, like headaches, dizziness, light or noise sensitivity. There's changes in thinking skills, like struggling to concentrate and not able to remember as well as they did before their injury. And then there's also emotional symptoms, so heightened irritability, feelings of low mood and anxiety. And when I was working with these individuals, I was noticing that there was such a prominent emotional component to their presentation. Again, entirely understandable when you think of how challenging a concussion can be for these individuals. And what the literature is telling us is that the emotional symptoms have a huge impact on how long people will experience post-concussion symptoms for. And we call these persistent post-concussion symptoms. In fact, if you've got a pre-injury mental health diagnosis or you experience really high levels of distress, anxiety, stress, low mood in those early stages of your recovery, those are the most robust predictors that you'll have ongoing or longer symptoms following a concussion. And that makes a lot of sense because a lot of the concussion symptoms that you experience are really non-specific. So every single symptom that you experience from a concussion you can experience in a whole other array in your life. So headaches, for example, a headache can be triggered by a concussion, but if you're really stressed, then that headache that you're experiencing from your concussion would then be ramped up by the stress that you're experiencing in your daily life. So it's become pretty well known in the concussion space that the management of individuals' mental health and how they adjust and recover from their injury is really important in order to be able to successfully get them to that stage of recovery. And so when I was working a lot supporting people with their mental health and supporting them to manage these big emotions that arise from their injury, one of the common observations I would note in these individuals was that they were often quite inflexible. And what I mean by that is that ability to shift your thinking or think in different ways around things. So there was a lot of rigidity in people's thinking around what's the cause of their symptoms. So somebody who may be very inflexible might see that the headache is only caused by their concussion. Whereas somebody who's a bit more flexible might be able to go, yeah, I've got a headache because of my concussion, but I'm also really stressed at the moment. So that stress I know might be impacting my concussion and my headaches. And so the people who are more inflexible are understandably going to get more distressed about their injury, about the fact that they're not recovering from their concussion. And then that stress is going to create this vicious cycle. So I was seeing a lot of that clinically, and I was also using a therapeutic technique called acceptance and commitment therapy. Now, ACT is a third wave cognitive behavioral therapy, and it's a next step from classical cognitive behavior therapy. So it's grounded in looking at how one's thinking skills, their thoughts, their behaviors impact their emotions and their mental health. Now, in ACT, it takes a slightly different approach. So rather than a more reductionistic approach to managing mental health, which is the basis of cognitive behavioral therapy, ACT takes this notion that we support people to manage their emotions in a way that's going to be aligned with their values. So, for example, rather than necessarily reducing anxiety or changing thought patterns, ACT looks at how you can have anxiety or have a difficult thought, but allow that to be present so that you can work with your values or work with the things that really matter. And so the basis of acceptance and commitment therapy is all around flexibility. So if we can support people to be more flexible in how they respond to their thoughts and feelings, then it's going to give them more space to be more attuned or more aware of their values or the things that matter. So, for example, a way that I often explain this to clients that I work with is that your values might be that you want to be a really good educator. That might be something that's really entrenched in you and something that you value. If you're a really good educator, but you might get really anxious about doing a lecture or public speaking. So somebody who has good psychological flexibility would be able to notice that anxiety, would be able to respond to it in a flexible way so they're not getting stuck or super invested in that anxiety. And that's then causing them to be more flexible in how they respond to it. So people who are more psychologically flexible would be able to think in that moment, my values are I want to be a good educator. I'm going to do this lecture. It gives me anxiety, but I'm still going to sit with that anxiety or allow that anxiety to be there so I can engage in a behavior that's aligned with my values. So for somebody who's quite psychologically inflexible, they might get really stuck in that anxiety or get stuck in that fear that if I do a lecture, then people might look at me in a certain way, or I might embarrass myself, or people might think I'm stupid because I don't know what I'm talking about. If somebody responds to those thoughts in a very inflexible way, you can get stuck in them. You can get really invested in them, and then they consume you. And then understandably, when you're consumed in those unhelpful thoughts or consumed in that anxiety, it leads people to move away from their values. So I'm so worried that if I do this lecture, I'm going to embarrass myself, then I will consequently not do that lecture. So people move away from their values or the things that matter because they are stuck in their thoughts or in their feelings. And so what acceptance and commitment therapy aims to do is it tries to facilitate people to become really attuned with their values, so the things that matter to them, and also learn skills and techniques to respond to their emotions in a more flexible way. A prime example of a psychological flexibility skill that I'm sure many of you are familiar with is mindfulness. So mindfulness is a technique where you are sitting with your emotion, you're being flexible in how you respond to your thoughts, and you're becoming grounded in the present moment. So irrespective of what you're experiencing in the moment, you are sitting with it and you're responding to whatever thoughts or whatever emotions you have in a really flexible way. So this is a very well-validated psychological therapy. It's got large growing. I think the latest research is there's about 700 published meta-analyses showing that the use of this technique is really helpful in a range of mental health conditions. So coming back to my work in concussion, I was using this intervention, particularly given that I was noticing that these individuals were often very stuck, often very avoidant of doing things that might trigger symptoms. And again, this is totally understandable because when you have headaches or when you are struggling with dizziness or you're struggling with this ongoing fatigue, it's understandable that you would stop doing things because you don't want those symptoms to be triggered. However, what can start to happen, though, is if those behaviours become entrenched or very inflexible, it takes you away from those things that really matter, which is your values and the things that are important to you. So often I was working with people with concussion who it felt like their life had just become stuck, they'd become lost, they'd just become their life had become defined by the injury. Everything that they were doing was to not make their symptoms worse, or that they were struggling so much by the nature of this injury that it had become everything that they focus on. So by shifting people to think more about their values, to think more about their ways of managing their emotions, to manage their thoughts in a more flexible way, I was finding that this technique was really useful at shifting people who got really stuck in their recovery. So if they were having more flexible responses to their thoughts, were more attuned with their values, then it was having some really great outcomes clinically. But as a good scientist practitioner, which is what we're trained to be as clinical psychologists, is that everything that we do is grounded in evidence. So we're trained to understand evidence, we're trained to conduct research to get this evidence so that we are providing the best interventions or the best service possible because there's evidence to support what we're doing. And so what was interesting is that despite me using this technique and despite me finding it to be really helpful, was that still to this day, there's no published research looking at the role of acceptance and commitment therapy. And I'm talking about published in terms of a well-validated randomized controlled trial. There's published case studies, there's published small little studies, but in terms of a really rigorous, double-blind, randomized controlled trial looking at the impacts of acceptance and commitment therapy in people with a concussion, the work is still happening somewhere, but is currently not published. So it got me really interested in trying to explore the role that psychological flexibility has in people's recovery from a concussion, and whether or not acceptance and commitment therapy may be a useful intervention that we could use for people who've experienced a mild TBI.
I have so many ways to go with that. There's so many questions to ask. Do you have any, Rudy?
I do. I was going to ask, do you have any specific, impactful or notable patient stories that you've had over the years that you can talk about?
I don't think I can, just in terms of protecting confidentiality, it's good not to highlight a specific case example, even keeping about it in general terms. I think it's more just that general observation that you see when people who live very busy lives or who have stress in their life before their injuries, is that sometimes the concussion can just be the straw that breaks the camel's back. And it's the thing that stops people. And then often these people are not very good at stopping or not very good at focusing on themselves because their lives are always so chaotic or so busy and stressful. And then so often this injury, despite it often being mild, and what we do know is that a concussion is not a permanent injury. It's got a really good recovery. We expect most people to recover from a concussion within 1 to 3 months. But often what happens is that people don't put their brain in the best place to recover. So often I say to clients that I work with, it's not the injury that happened to your brain that's most important, but it's the place we put your brain after the injury that's going to give it the best opportunity to recover. So our brains are really resilient. They do recover well, but often what happens is that lives are so busy. Sometimes people don't necessarily know that they've had a concussion or sort of just flog it off. Oh, I just had a quick fall. I knocked my head. I was feeling a bit dazed and I had a bit of a headache, but it's all good. And then we'll go back to working 40, 60 hours or managing a busy household. And then the brain struggles to resolve the physiological changes associated with the concussion. And then patterns start to emerge. So that headache continues, or those memory difficulties at work continue, or that irritability continues. And then you get a bit of a snowball effect. So that the struggles with managing that ongoing headache continue to cause stress. And as we know, that stress then feeds that headache and keeps the symptoms going. So I think it's definitely a lot of those observations that people understandably fall into these patterns, and they just can be really unhelpful patterns, particularly for a concussion.
Because you spoke about general symptoms of concussions, I was interested in knowing, do concussions in different regions of the brain affect you differently in terms of, because you were talking about surgeries earlier, where you're looking at tumors and based on where the surgery is, you measure different cognitive tasks. Does the same kind of apply for concussions?
So in the international concussion literature, they define concussions into a complicated or an uncomplicated concussion or mild TBI. So an uncomplicated concussion has been when there's been no focal or localized damage to the brain. And so that the pathophysiology, or the scientific term, or the actual what's going on in the brain as a result of a concussion, is often referred to as diffuse axonal injury. And how I often explain this to clients that you're working with, it's like a wave hitting your brain. And so if a wave hits your brain, it's going to go kind of backwards and forwards. So there's often no focal effects of a concussion. And what it does is it just sort of slows your brain's ability to operate effectively as a whole. And so it's often like a car engine, and this is often an example I give too. It's like the car engine is just not operating as a whole as effectively as it was beforehand. There's nothing wrong with the actual individual parts, but because that wave has gone through your brain and changed some of the ways that your brain functions, it has this overall generalized effect. And so that overall generalized effect means that people's thinking just gets slower. It just doesn't feel that their brain is operating as fast or as efficient as it was previously. And all of those effects cause the brain to struggle. And what the brain does cleverly is that it signals that it's struggling. So a headache is literally your brain saying, hey, just slow down, I can't manage this. It's trying to tell you to stop. And fatigue is another example of that. So your brain is signaling to you, hey, I can't cope with the demands that you're putting on me right now. Can we slow down a bit? But the challenge that I alluded to earlier is that, people often struggle to slow down in those initial stages of the injury because they don't know they've had a concussion, or because they're just getting on and going with it. So that's the uncomplicated concussions, but we know that a concussion can also lead to what's called more kind of focal or localized areas of damage in the brain. And that would be like, and again, I always give examples because I explain these to patients. It's sort of like you're standing in front of the beach, that wave that I talked about hits you. So the wave hitting you would be where it might sort of focus within the brain. So it might be in the front or might be in the back. But the wave also still goes past you. So you might have a really localized area of significant damage, but you still have those more generalized effects. And if we have patients with these more complicated injuries, is that the area of the brain where that localized area of damage is more likely to have more significant issues in that area. So we know that the front parts of our brain, called the frontal lobes, are really important for problem solving. We call this executive function, being able to reason, be able to plan, be able to organize. So if somebody has a more complicated concussion where they have damage that's been identified, and that might be a little brain bleed localized to that frontal region of the brain, they may be more likely to have difficulties in those more specific skills that part of the brain is involved in. So they may be more unorganized, may struggle to do more complex tasks, while still also having those generalized effects.
How does your work relate to neuroplasticity?
That was what I was going to ask.
I just don't know if it's like related enough.
No, I was going to ask it this way. Considering you spoke about how like some more severe brain injuries in your work, you saw them improve quite quickly. Do you think it is because of this thing? It is because of plasticity in the brain and how that works, but also in like the milder injuries, people aren't giving themselves the time to recover, while in a more traumatic one, you do. Yeah, yep, definitely. So there's some really good evidence to highlight the role that the brain has in adapting and adjusting to the effects of a traumatic brain injury. And this, again, highlights why you see recovery. So the brain can restore that physiological change that's been occurred, but the brain can also compensate in different ways. And that compensation at a very cellular level could reflect plasticity, or the brain changing the way that it produces or it operates. So one example of plasticity in traumatic brain injury arises when there is more of a permanent effect of an injury. So it's been a long-standing
deficit that's arisen as a result of the traumatic brain injury. And neuroimaging studies have found that other areas of the brain can start to take on more of that load. And that's an example of neuroplasticity. So that part of the brain may be more strongly activated in neuroimaging studies. That part of the brain may have a higher level of volume. And that's all reflective of the fact that, yep, there's still these deficits, but the brain is starting to compensate and to function around that. And one example I often give to people who've had a concussion is if we're thinking about a diffuse axonal injury, and I know that's a big scientific term, but we know that the brain is full of all of these neurons. And the neurons are the basic cellular structure that produces electrical impulses. And those electrical impulses are how the brain communicates, it sends signals. So, for example, I'm sitting here clenching my fist. That clenching of the fist is all occurring because these neurons in my brain are sending these signals. And they send these signals down these pathways that are called axons. And axons are very much like how I explain this to clients is that if you think of two little towns, the towns is the cell body or the hub of the neuron, and the towns are connected via a motorway. And so when you travel from one town to the other, you go down that motorway. And that's exactly how our brains work, is that they produce a signal in one town and that signal goes down the motorway. And when there's a diffuse axonal injury, there has been some damage to that motorway. And that's reflective of that force. Remember that wave coming through? That wave's going to hit the road. And that road may no longer be as useful to drive along. It's kind of now will become cracked. And so that the signals or your ability to travel down that road is impacted. It takes you now longer than it would have done previously. And so what your brain starts to do is it starts to send signals via alternate routes, because those routes haven't been as impacted by the shearing forces that has been caused by the concussion. And so how I say this to clients, it's like you're going down the fast highway, the direct route, and what's happened after your concussion is that your brain is now taking the scenic route. It's going down the longer highway. And what does that mean? Well, it means that your brain is working harder. Those signals take longer. It takes more energy, and all of those difficulties then become evident the harder and harder and harder your brain works.
So the next question I had was, because you work with so many patients, and with the way ACT works, is it different between like different groups of people in terms of cultures and things like that, and how you would approach treating them?
Really good question. There is definitely some international work looking at how you can apply this intervention to different cultures. It's very applicable across cultures, and the reason why it's often very applicable is that you're honing in on people's values. And people's values are so different, but there is obviously a real cultural component that can drive people's values and what matters to them. And so if we can have those discussions, very clearly and discuss them really openly around how culture impacts those values, then it helps guide the interventions and the techniques that you utilize. There's one of the exercises that can be used is there's a values card. And so a values card is basically a technique that helps to facilitate people to understand their values better. So you have like 20 values put in front of you, and then you work with your psychologist and you go, okay, these ones are really important. These ones are sort of moderately important. These are less important. And then you go to your most important list of values, and then you work through those to try and capture two or three really important values. And that technique has been adapted, and there's I can't remember his name, but he's from the University of Waikato, who's adapted that technique and looked at Māori-specific values as a way of being able to really focus that on a culture-specific intervention. So, yeah, really, really applicable.
If could you elaborate more on that in terms of the Māori perspective?
My understanding at present is that I don't know if there's any specific pieces of research that's been conducted with just a multi-specific population. We know that cognitive behavioural therapy, there's some good evidence that that's been adjusted and adapted. A colleague of mine, Dr. Simon Bennett, has adapted cognitive behavioural therapy to reflect cultural differences. And, part of being a clinical psychologist is that we are trained to have a bicultural competency in how we work. So we get cultural supervision. We have culture as a really important part of our training to be attuned to people's diversity, and to be able to sit with a space where you can have discussions and really explore differences in culture. And so although it may not be kind of related to specific interventions per se, there's a real grounded competency that clinical psychologists and neuropsychologists, rightly so, have to be able to work effectively with our clients who are so diverse, and we use those general skills in every work that we do. So
let's move into your current research in particular. We know you're working with mild concussions or mild traumatic brain injury.
Mm-hmm.
Could you talk about what kind of research you guys are currently conducting in your lab?
Yep. So as I mentioned earlier, the notion of ACT is that we want to target psychological flexibility. So if we can make people more flexible in how they respond to their thoughts and feelings, then it may give them a way of being able to manage the distress that arises from a concussion more successfully. And so in taking this approach, one of the important things that we have to do is identify whether or not psychological flexibility actually influences outcomes from a concussion, right? So if you're trying to use this technique that hones in on this specific, what we call this mechanism, then is that mechanism actually important for outcomes? So for the last couple of years, that's been the focal point of my research, is looking at whether or not people who are more or less psychologically flexible, are they more likely to have worse outcomes? So I previously worked with a concussion provider. So in New Zealand, we have concussion services throughout New Zealand. And so if you experience a concussion, then you can be referred to these concussion service providers for rehabilitation and treatment. And so one of the research studies that I set up was we measured patients who'd entered these services psychological flexibility as soon as they entered the concussion service. And we measure it through a self-report. So we ask questions around how do people respond to their thoughts and feelings? Do they respond in a really flexible way? Or are they more likely to be avoidant or to think of their thoughts and feelings as being very true? And very true is indicative of an inflexible way of responding to them. So we would measure patients' psychological flexibility as they entered a concussion service, and then we determined whether or not psychological flexibility impacts outcomes. And so we would monitor these patients over time and review how they were doing. And our main kind of prediction or our hypothesis was that if an individual has higher levels of psychological flexibility, so they're more likely to respond to their thoughts and feelings in that more flexible way, then they would have a better recovery over time. And we've been able to support that hypothesis, which is really cool because it shows that actually the intervention or the technique that was focusing on flexibility needed to focus on it for a reason. So we now have this empirical justification that if you have more inflexible thinking, you're more likely to have higher levels of post-concussion symptoms or worse functional outcomes at 6 months post your injury. So that was sort of the first phase of our current research, which is to illustrate that flexibility is important in this population. And now that we have empirical justification to show that it does, our next phase is to now target it through an intervention. So at the university, there is a psychology clinic called the Victoria Psychology Clinic, where psychologists see patients and clients and work with them on a range of different presentations. And so we're just in the process of setting up a feasibility trial, partnering with these concussion providers where people with a concussion who are experiencing high emotions and might need some support to manage those would be referred to our clinic, and then they will be randomly allocated into whether or not they receive acceptance and commitment therapy, the technique that tries to support that flexibility, or a standard psychological intervention of cognitive behavioural therapy. It's a feasibility trial because we're just setting up some of the parameters, and it's funded by the Health Research Council of New Zealand. So a big shout out to them for thanking funding of this study. And it's also in collaboration with the Traumatic Brain Injury Network at Auckland University of Technology, alongside a mentor of mine, Professor Alice Theodem. So acknowledging them for their input into this project. So we very soon we'll be setting up this randomized control trial feasibility study to determine whether or not, if we hone in and actually start to target psychological flexibility with the psychological technique, we might be able to support or improve outcomes. So it's a feasibility study, the idea being that we're testing out this trial. We're testing out this intervention that we've developed. We're looking to see whether or not we can show that we can set up for a full randomized control trial, which would be the overall goal, is that we can then have the frameworks in place to put in a really rigorous methodologically based study that can randomly control whether or not people receive ACT or CBT or another psychological intervention, and illustrate whether or not this technique might be helpful for supporting people in their recovery from a concussion.
Just moving back a bit to, you said you went through the clinical psychology program. Is there something you wish you'd known going into that, or something you've learned since that might have been, you sort of be part of the curriculum, or something that you wish you'd known, I think, as a person going into that program?
I think when you're in the program and you're studying, you get exposed to so many different avenues of clinical psychology, and that's totally understandable because you're covering child mental health, you're covering adult mental health, you also cover corrections, and you're covering neuropsychology. And when you're in the program, it can feel quite overwhelming, and plus you're doing your research. So you can often feel, quite stretched, and you might start to ask questions about, why am I studying this? I don't think that that's relevant. But then when you leave the program and you start working, you start to really appreciate how much you learned in your training and how grounded your skill set is, because you cover so many different aspects. And so when you work with patients, you get exposed to so many different types of presentations, and things come up that you never thought would come up, or that you hadn't anticipated, and you went in thinking it would be like this, and then it's suddenly like this. And then so now reflecting back on your training, there's this real appreciation for how much you get exposed to, because that knowledge and those grounded competencies really bode well for what's actually out there. And you don't often see that when you're in the midst of it. You just think, I've just got to get through this, or I've just got to get through this, and I've just got to get through that. But it really does bode well.
Would you have any advice for people who might have had a concussion, or if they've had like a hit to the head or something and have not actually checked out? Do you have any advice for like people like that in terms of like treatment, taking care of their things generally?
Yep, get support. That's the biggest one. And also stepping back from that, there is a need to have a bit more recognition and awareness around concussion. So a concussion is not just a loss of consciousness. And if you've knocked your head, you're feeling a bit dazed, you're feeling confused, you're feeling a bit out of it, and you're just a bit tired the next couple of days, you've experienced a concussion. Your brain's physiology has changed. And what you need to be able to manage, and this is where it becomes really tricky, is that you need to be able to have an optimally functioning brain to be able to then help your brain recover when it's not in a good state. And that's a little bit of a conundrum, but it also highlights how important it is to be able to have people supporting you through that recovery, because it gets really hard, and symptoms of a concussion are awful, and they can be particularly challenging for people. So if you've experienced a concussion, advice is to go to a doctor straight away, have that recognised. We know based on the international literature now also that there was this previous held belief that one needs to completely stop everything that they're doing for a prolonged period of time, up to 2 weeks of just rest. That's no longer supported now in the literature. So we advocate that for 1 or 2 days, you just really slow back and just take things easy. But also it's really important that you start to graduate the activities that you do. So the basis of concussion recovery is termed this graduated return to activity. And that's a really hard thing to do in isolation. It's a really hard thing to do without somebody putting that plan in place for you, because you don't often necessarily know what state of your recovery you're in. The challenge as well with concussion is that you may have a good day and then suddenly you have a bad day, and it's really hard to recognise why there's good days and why there's bad days. So with a graduated return to activity, we try and get people to start gradually exposing themselves to activity. So it might be, rather than doing a full day at work, you start doing an hour of work a day. And then over time, you are building up that level of activity. So the idea being is that your brain can cope and manage the demands that you place on it at the same level that it is in terms of their recovery. I talk to patients about their brain injury as causing a change in their fuel tank. I do this for a number of different ways. A fuel tank takes away from it just being concussion as the focus point, because recovery management is all about the fuel tank. And so if we support people to manage their fuel tank, we also look at all the other factors outside of the concussion that's also impacting their fuel tank. So for example, stress. If you've got lots of stress in your life, that's going to impact your fuel tank. And so if your fuel tank is already low because of your concussion, and then you've got a really stressful week, you're at uni, you've got study to do, that tank that's at 60%, your brain took 40 of it when it had that knock. It's now going to take an extra 40 because all of that energy that goes into feeling stress means that fuel tank's only 20%. So we work with patients to help support their fuel tank. And so if your fuel tank is 60%, ideally we want you operating at a level that's around that 60% mark. If you overdo it and your activity's at 80, 90%, we then just boom and bust, and we can't manage things. Conversely, if you're only operating at 10%, but you're actually at 60%, your brain doesn't get to be exposed to how it operates in everyday life. I talk to patients that your brain's a muscle. We want to strengthen it. We want to be able to expose it to what it does on a daily basis. But concussion recovery is like training for a marathon. If you ran a marathon and hadn't done any training before, you're just not going to cope and you're not going to manage. And often what people do is, in those early stages of their recovery, because life is so busy, their brain is like trying to run a marathon when they've never done any training before. So our goal is to train you, and that training takes time, it takes support, it takes recognition that there is been an injury. But we know again from the literature that early recognition of a concussion, early intervention, early support are some of the best predictors of a successful recovery. So yeah, that big advice is don't just flog it off. If you've got concerns, if you haven't lost consciousness, but you've still felt some of those symptoms, you've experienced a concussion, go to your GP, get that concussion recognised. We're lucky in New Zealand that we have ACC, so being able to have a body that puts support in place for a concussion, which is an accidental injury, means that you can get treatment early on if needed. So,
awesome. That was great. I think looking at time, we'll just jump on to the final thing which we do, which is consistent between all our guests.
Mm-hmm.
We're going to ask you a few rapid fire questions, and all you need to do is answer them as quickly as possible.
Mm-hmm.
Right. Summer or winter?
Summer.
Movies or TV series?
TV series.
If your life were a movie or series, based on your previous answer, so a series, what genre would it belong to?
Comedy.
Morning, noon, or night?
Morning.
Outdoors or indoors?
Outdoors.
Cats or dogs?
Dogs.
Controversial. What's your weapon of choice?
Language.
Which superpower would you like to have?
My mind's going to invisibility. I don't know why, but that's where I went to.
Mark Olson was talking about how it's teenage boys' favorite choice, invisibility.
So that's who my mind still is. Teenage boys, invisibility. Yep.
Take of that what you will.
Is a hot dog a sandwich?
Controversial. No.
Yeah, I agree. Yeah. What is your least favorite type of music?
Heavy rock.
What is your favorite food or cuisine?
Favorite food. Cuisine, I think, would be Thai food.
What is the ugliest fruit or vegetable?
Mushrooms are pretty ugly.
Really? Okay.
We're not happy with that one.
But do you like mushrooms?
I love mushrooms.
Okay.
I was just thinking about, those big portobello mushrooms.
Yeah.
And you flip them over and they've got,
Gills.
Yeah, gills. Perfectly explained gills, yeah.
All right. If you could be any animal, what would you be?
Dolphin.
Pretty smart with their language, aren't they?
It's a bit of a theme there.
What is the worst thing you've ever paid money for?
Water.
I think most places you need to pay for that anyway.
Well, I don't know why I went there, but it's pretty annoying to have to pay for a bottle of water when it's
everywhere.
Yeah.
What ridiculous thing has someone tricked you into doing or believing? Paying for water.
Paying for water, because I have had to pay for water. Yes, good one. I'll take that.
If you could live anywhere in the world, where would it be?
New Zealand.
What quote or saying do people say which you think is complete bullshit?
We need to be happy.
You think it's better if we can just be miserable?
No, it's just this notion that there's the work called the happiness trap, this notion that we have to be happy to have fulfilling and meaningful lives. And it creates this notion of emotional control, because life is hard and life is difficult and we go through a wave of emotions every day. Our emotions are like the weather. And so if we set up this notion that we have to be happy, then we're just setting ourselves up to failure. So we can have meaningful lives, but let's not take away from the fact that there's also hardship and there's big emotions and we should be allowed to be able to experience them.
Yeah, very true. What reality TV show would you like to see made?
Reality TV show. I'd like to see what happens behind talk shows more, rather than just the actual guests getting interviewed, but all the stuff that happens behind the scene. I reckon that could be a good reality TV show.
Cool. That would be great. We should have recorded this behind the scenes.
Yeah, exactly.
Inception.
Yeah.
Okay. If you were not doing this, what would you be doing?
I had when I was on that verge of applying for clinical psychology, I had done my first skydive. And so I had said to myself, if I didn't get into the clinical psychology program, I would train to become a skydiver and just travel the world skydiving. So I think I would do that.
That's great. I've got a guest lined up in the future who's a skydiver.
Oh, very cool.
That is so dope.
Yep.
All right. What type of researcher is most likely to win a drinking contest, and why is it a neuropsychologist?
Well, I think the neuropsychologist would have very good awareness of what their cognitive strengths and weaknesses are. And so they would make the drinking game very consistent with their cognitive strengths and weaknesses. So, for example, for me, having good visuospatial skills, I would do something like beer pong over something like some memory or verbal memory-based task.
That's smart.
That's really smart. You thought about that.
All right. The very last thing. If you could give us one piece of general life advice to leave us with, what would it be?
That it's okay to feel hard emotions. And that's a very acceptance and commitment therapy-based approach, is that, we do have this innate emotional control where we say to people it's okay. When somebody is crying, our first response is it'll be okay. But sometimes it's actually okay to sit and acknowledge and say, actually, this is hard right now, or that you're feeling sad. And that we need to, as a society, get to a place where we can be more healthy with negative emotions rather than focusing on this false fallacy that we have to be happy or we have to have positive emotions. So it's okay to have those negative emotions.
That was great. Well, thank you so much. If anybody wanted to get in contact with you, how would they do that?
My email's on the Vic staff directory, so you can find me on the Vic Psychology staff page.
Awesome. Well, thank you for that. Thanks for coming on. Thanks, Royden, as well, for jumping in.
Cool. Thank you for having me.
And yeah, until then, you can find us on all our social medias. You can hit Josh up if you have any more questions with him. And until then, thank you, and be in touch with your negative emotions. Bye.